Thank you, David. Next, we're going to have John come back up. John Pandolfino, again, needs no introduction. And he's going to talk about something that I think is unique to the Chicago and Midwestern experience, which is the dissatisfied post-fundolpication patient. We don't see that.
Because we have a good airport and they fly in from all over the country. So once again, not an easy topic. Thank you, panel. Here are my conflicts. And kind of want to talk about this, and once again, this kind of theme coming around collaboration and trust and these relationships that happen. If you look at our group, I don't have a nice picture like Blair, but we have a group of surgeons, we have gastroenterologists, endoscopists, psychologists, a dietitian, and ENT doctors who kind of all work together. And it was funny when I was putting this together and I was thinking about this particular talk and our approach to these complications. It was interesting to me that I kind of realized that what we kind of do at Northwestern is we pair a surgeon and a gastroenterologist together. And we have clinic together. We actually have clinic in the same space. We're talking together about patients. And Nat Soper and Peter Karillis had clinic together. And they would see pretty much most of the fundoplication complications and the patients who were dissatisfied. Then when Eric and I started working together, we developed our practice. All of a sudden, we started seeing them. And Nat and Peter didn't see them anymore. And now that I have Dusty Carlson and Eric has Ezra Teitelbaum, now they're seeing these patients. So that's kind of how it works at Northwestern. So, but that being said, I think we all work on these patients together, and we have a multidisciplinary conference that literally is kind of one of my most favorite things throughout the month. We have it twice on a Tuesday night, and we get together, and we talk about these really difficult cases, and we try to come together with a plan to help these patients out, because they are really put in a very difficult position. Because really what we want to do for these patients, give them a quality outcome. We want them to get the best treatment, the lowest risk, and the lowest cost. And unfortunately, too, we also want to, deal with the personalized approach, and we have to deal with all the issues that, what does the patient want? Some patients don't want to take PPI. Some patients don't want a fundoplication or operation. So we have to kind of deal with those particular issues. So why is the dissatisfied fundoplication patient important? Well, first off, what are the reasons why they're dissatisfied? Well, one is maybe they had the wrong diagnosis. Maybe this wasn't reflux. I'll tell you, I've seen a rash, and just to highlight this, I have 3 patients that have been referred to me who had fundoplication for refractory esophagitis, and they had lichen planus. So just keep on the watch for that. That is shocking to me to see that happen to that point, but it once again goes back to getting a good endoscopy, getting mucosal biopsies if things don't make sense. The operation could have failed. Certainly, patients come in expecting to have no reflux at all, and maybe it's a little bit too loose, they're still having reflux, and that could be a reason why they're dissatisfied. The operation could become disrupted. We've had many cases where patients get a fundoplication, and then they think they can go out and, once again, not lift bags of concrete, but go out and exercise vigorously, and they disrupt their wrap, or they get into an accident, or they fall. And then, of course, there are the complications that occur that we also have to deal with. You've seen this slide, or at least some type of revised version of this slide, talking about the complication rates with primary fundoplication, and they're not small, and they're not insignificant. David did a really wonderful job of talking about the vagal injury component to this and all the things that can happen. But it's really important to think about these in the context of what are things that people can live with and what are things that people can't live with. And I'll tell you, much of the time I spend with these patients is really trying to figure out, can they live with this? Yeah, I know it's disrupted or a little slip, but sometimes the fix is worse than what they're at right now, and I don't want to make their quality of life worse. So in many aspects, if I have to bring in a gas bloat patient once or twice a year and they get a little bit of narcotics and an NG tube and get decompressed and they're fine, that might be okay, and I might accept that. And this is the other reason why I think it's really important. And this is actually from Samit's group. When you actually look at it, when you look at primary fundoplication, that's our best chance to help the patient. That's where we know we have the best opportunity to make the patient better. But as you get to the first redo, the second redo, and the third redo, the likelihood that these people are going to have a good outcome is very low. In fact, I will tell you at our conference, and people hear me go, when we have someone with a second redo, I always say these people are never going to be the same. They're never going to be better. We have a horrible rate of making these people feel better once they get to that level. And that's really where I think if we can start from the beginning and get things right from the beginning, that's where things really will turn around for this particular process. In terms of the dissatisfied fundoplication patient, this is from a paper that Eric and Raina and I wrote, and just looking at the diagnostic evaluation before fundoplication, I think big mistakes are made when people don't get these standard tests. I still am shocked when I see these patients once or twice a year who come in with refractory symptoms after fundoplication, and they have achalasia. And it's not pseudoachalasia, it was primary achalasia, and someone didn't get a manometry. So I think that doing a good workup up front, getting the patient ready, and I always say that my job, for Eric is, really to get that patient and put him up on a tee for him and give him the best candidates and phenotype them appropriately. So I think it's very important to use these tests. And it's also important to remember that, these tests are not competitive. They're complementary. An esophagram can do a lot of very good things that a manometry can't. And I tend to get a lot of these tests and use them together. This is a very nice, beautiful illustration from Blair Jobe from a publication in the Red Journal where he shows what a fundoplication should look like in the Retroflex View. And you can see it. It looks very nice. It's not too long, but you see those beautiful perpendicular folds. So this is something that when you retroflex and see, you'd be very happy with that particular outcome. And I think that's another thing that may be lacking in terms of the gastroenterologists who are actually taking care of these patients is they don't know the anatomy. They don't know what to look at. They don't know what's important. And I also do think that it is important to insufflate, pull the scope up and down, see what's going on with the laxity of that esophagogastric junction. So very important to spend a lot of time on that Retroflex View. So when you see these patients, as I mentioned, endoscopy is extremely important because depending on what I see, I'll know what I could possibly do for this patient. And unfortunately, as a gastroenterologist, the opportunities to help these patients are pretty limited. And really what the main decision that we have to make, especially in conjunction with our thoracic and general surgeons, is who's going to really be a candidate for a redo operation. So you can clearly see that one patient is disrupted. You can see that the folds are now, instead of being perpendicular to the scope, they're actually running parallel. So that would be a patient that you'd be a little concerned that they have reherniation and recurrent reflux disease, probably would have a positive pH study if you studied them. Then, of course, the patient with a partial disruption and paraesophageal hernia. You can see that the crura is disrupted and the wrap is kind of literally moving up and down into that area. And you could just move the scope up and down and see that happening. This is someone who most likely I'm not going to be able to help that much, but it doesn't mean that I'm not going to try. And then, of course, the person who comes in with a completely disrupted crura, reherniation, maybe a little bit of the wrap still intact up there in the chest, but this is also something that I'm going to have a very little effect on unless this is someone who has a really tight obstruction. So as I mentioned, I tend to get a lot of diagnostics on these patients. I want to know their anatomy as best as I can, and I want to know their physiology. I want to know what their function is. So at the very start, I'm going to get an endoscopy. I'm typically going to get a barium study because many times you're not sure where you are when you're sitting in there. You may think there's no hernia, but there's a nice little paraesophageal thing sliding along the wrap that you would have missed if you just looked at the endoscopy. I tend to do manometry, but I will tell you that more often I'm using flip because now I can assess how tight that esophagogastric junction is, and I can also get some assessment of the peristalsis. So I'm typically doing that during that first endoscopy I'm doing when I'm evaluating these particular patients. So I combine these tools. I look at them together, we run through them. Sometimes they're contradictory. Sometimes they don't make sense. Sometimes the manometry looks completely normal and the flip looks tight. Well, you have to realize that these tests do very different things. So when you look at this in the NFOS, the Retroflex View, when you look at this patient in the Retroflex View, it didn't look all that bad, but of course when you look at NFOS, you can see that hernia sticking up in the chest. So this is my diagnostic workup. for normal anatomy. I know Prakash, if he's in the audience, is going to give me a hard time because I tell everybody I hate algorithms. Because when you see an algorithm like this, it really means that we don't know what we're doing. When you're trying to get all these lines, trying to fit together. But I do think at least they provide a good starting point and at least an avenue for where you can move and think about the patient. And I think, as I mentioned, I'm going to get an endoscopy, probably a flip, and at least an esophagram on almost all of these patients when they come in, especially if I'm concerned about their anatomy. But when I do see the patient who has normal anatomy, meaning that they don't have a completely disrupted wrap, they look like the wrap is below the diaphragm, I'm really trying to assess, is this just a little bit of disruption? Do they have esophagitis? If they don't have esophagitis, I'm looking for evidence of obstruction. Is there something I can do for this patient to help them? And really, at that particular point, what I'm trying to do is, as a gastroenterologist, is this someone that I can do dilation on? I'll tell you, we do TTS balloon all the time. It doesn't really work all that much. I mean, if we're really going to do something for these people, we have to do pneumatic dilations. So really, that's what I'm doing here. I'm trying to assess the anatomy. If it looks normal, the wrap is below the diaphragm, there's not a big paraesophageal component, those are the patients that I will do a pneumatic dilation on. I'll typically start with 30, go up to 35. I rarely go up to 40, because if I don't really get a good response with 35, those are probably the patients that are going to need a redo operation. In addition, when I'm looking at these particular patients, the graded dilation technique we use, there is a ESO-flip balloon that we can use that does allow you to do this without fluoroscopy. So if you want to do this, but I do try to plan these patients so that I do have fluoroscopy. One of the little things that I try to do. But once again, I fight with my interventional guys over the fluoroscopy rooms. We have a lot of patients who can't tolerate sedation. We do MAC there. I might not be able to get fluoroscopy, and that's where that ESO-flip balloon will work. The reason why I like that also is that I will tell you, I've had a hard time sometimes assessing strictures in these patients. And there have been times where I've done these graded dilations where I get to 20, nothing happens. I go from 20 to 25, and there's a big tear because of all the fibrosis and the injury there. And if I would have done a pneumatic dilation, I might have killed that patient. So that's one of the things that I do, that I've done more and more, is probably do this graded dilation with the ESO-flip, going more from 20 to 25 and 30, and then going to 35. So once again, going through this route. I do think, when we do see patients with abnormal anatomy, I do kind of throw up my hands. One of the things that when I see someone with a disrupted wrap or a slip wrap, especially if they're having dysphagia or signs of obstruction, food impactions, there's probably not much I'm going to do there, because trying to open up that area in a slip wrap is very difficult. I will tell you, though, if my surgeon asks me to try, I will try. And I'll typically do that as long as the slip wrap is below the diaphragm. I'll try to do that, because if I do it and it's above the diaphragm, I'm just going to pop this thing open, and this patient's probably going to be worse. So typically what I'll do is I'll try to assess the situation, but in the end, what I'm really focusing on is how bad is this anatomical defect? So if they have a disrupted wrap and there's a hernia, but the hernia is less than 5 centimeters, and their reflux is not that bad, I try to convince the patient to live with it. Because I know if they go down that route and they get that second operation, and if they need that third operation, that could be a really big problem when we're setting them up, for doom, for failure. I mean, vagal injury, perforation, the operation's much harder, and eventually they may wind up getting even esophagectomy at that particular point. The other issue, too, is when I make that decision that they can't do something, then we have to start thinking about what are the operations that we can actually think about here. So we always come back to the option of, all right, do we do a redo operation? And I'm not going to steal Sumit's thunder, but should we do a redo operation, or should we do a modified gastric bypass-like operation where we divert this? And I do think that it is very important to assess gastric function. So one of the tests that I do often in these particular patients, regardless of what their symptoms are, I think when we're trying to stage out what we're going to do for them, having an idea what's going on their gastric emptying study is extremely important. But remember, if these people do have some obstruction, these can be falsely read as having abnormal gastric emptying. So it's probably a good idea to actually look at the studies, because if this is all sitting in the esophagus, this may be misinterpreted as an abnormal gastric emptying study. So in those particular patients that we show don't have a functioning stomach, these are the patients that we typically refer for gastric bypass, like revisions. But if the patient does have a stomach that looks like it's operational, those are the patients that we will try to do our best with a second or third redo operation at those particular times. The slip wrap is a very interesting problem, and I think, once again, I still try to address it the same way. If there's a mild slip and there's a little bit of herniation there, I really try to convince the patient to live with it. So as long as they're not aspirating at night, having nocturnal regurgitation, losing weight, I will try to do my best, and this is where my psychologist will help. We'll develop some coping skills and really try to work them through that particular pattern. So in the end, I think this is a very complicated problem. It really requires a lot of trust between the surgeons, the gastroenterologists, the psychologists. I really try to avoid reoperation if I can at all, to keep the anatomy as normal as I can. And I really would tell you, upper GI endoscopy and some type of assessment of motility and EGG opening is really crucial when you manage these patients. Thank you very much.